Hey everyone, Sally here. We're going to do kidney disorders. So what are the roles of the kidneys? So they have many roles. They filter our blood and toxins, rid us of our urine, help maintain our blood pressure, electrolytes. They produce erythropoietin, which forms our RBCs and breaks down medications. So you can see as we talk about these diseases and disorders, I want you to kind of keep this in the back of your mind because if our kidneys aren't working for whatever reason, a lot of these can be disrupted. So we might have an excess of fluid volume. We might have excess waste or toxins in our blood because we're not filtering it properly. Our electrolytes are going to be out of whack. Most of the time, they're going to be elevated when we have kidney disorder. Again, like I said, our blood volumes are possibly going to have hypertension. Our vitamin D isn't synthesized, so we then cannot absorb calcium properly, so our bones can be weak. We will have low RBCs. Our drugs are not going to be broken down, metabolized properly, and so um, that would increase the risk of us having toxicities for the medications that we take. And then we also cannot metabolize hormones. So these are the roles of the kidneys. There's another item that we need to talk about when we talk about the kidney, and that is the renin-angiotensin-aldosterone system, or the RAS system. And this really just tells us the order in which and the items in which are stimulated within the system. So first we have our renin, and then we have our angiotensin, which our goal is to get to angiotensin 2. And then we have aldosterone, in which angiotensin 2 is one of the things that angiotensin 2 stimulates is the adrenal glands. So how do we start this out? We start out with low blood pressure. So if we have some type of low blood pressure, blood volume to the kidneys, and the kidney is not being perfused properly. When the kidney is not perfused properly, the juxtaglomerular cells, known here as the JGA, release renin. It's one of the first, that's the first action to retain and increase blood volume is renin. So the juxtaglomerular cells release renin. The renin activates the angiotensinogen in the liver to convert the renin into angiotensin 1. So now, as we can see, we've got our angiotensin 1 now, and our ACE, which is our angiotensin converting enzyme, that actually works on the endothelium of the lungs and kidneys. That converts angiotensin 1 to angiotensin 2. Now, angiotensin 2, remember, is where we want to be because it is what triggers the 4 events that can help with our blood volume. So first, what it does is it constricts blood vessels. So it's a vasoconstrictor. And then it can stimulate the kidneys to retain sodium and water, which then means that we are increasing our blood pressure. Remember, we started with low blood pressure, low perfusion, so we want to keep the sodium and water we want it to be reabsorbed to increase the blood pressure. It stimulates the adrenal cortex right here that then releases aldosterone. Aldosterone helps retain sodium and water. And it also stimulates the posterior pituitary gland, where antidiuretic hormone, or ADH, is stimulated. ADH, also called vasopressin, it reabsorbs water from the kidneys and causes peripheral and arterial vasoconstriction. So all of these things end up increasing our blood pressure. So this is one way that our body and our kidneys can increase our blood pressure naturally. Okay, so this is one of our first disorders, urinary tract infections. They're actually classified by their location in the kidney system. UTIs in the urethra are called urethritis. In the bladder, it's called cystitis. The ureters is uretitis, and kidneys is pyelonephritis. So these are all UTIs that can start in any location. The majority of these, though, are either from systemic infection or the infection ascends up from the urethra to the bladder to the ureters and then to the kidneys. At this point, because it's infection, it would be considered intrarenal, and so now we could go into acute kidney injury. There are many causes for UTIs, which range from anatomical causes all the way to weak bladder muscles. Females are more likely to have UTIs due to the close proximity of the anus to the urethra. And blockages such as kidney stones are also very common. The medications that we use for UTIs are antibiotics to treat the infection. The infection is typically E. coli, and we've gone over these antibiotics in previous slides. We use bladder analgesics such as pyridium, which decrease pain in the bladder and the urethra. They do this by adhering to the mucosal lining in the bladder and the urethra. Anticholinergics such as oxybutynin, this decreases spasms. We need to take extra precaution with this medication, though, due to its side effects, which we will discuss later. Pain medications such as NSAIDs, that's good for decreasing the inflammation of the UTI as well as for pain. And lastly, bladder protectants such as pentosan polysulfate, which coats the inside of the bladder, decreasing irritation. When you think of this bladder protectant, we use it quite a lot. It actually coats the inside, like I said, of the bladder. So think of like something like if we have a GI distress or something, we'll take Pepto-Bismol and it coats the inside of our stomach to help irritation. This does the same thing as the medication is taken orally, and then as it goes through the system, gets picked up on the bladder mucosa to protect. Okay, so acute glomerulonephritis is an immune response within the kidney, typically caused by a strep infection. It can start with an antigen-antibody reaction within the body, and then that causes damaged structure of the glomeruli. So when we have damage of the glomeruli, our nephrons have dysfunction as well, and then that disrupts the filtration. Again, because it's can be caused by a strep infection, typically we're going to have inflammation in there as well. And so we have some damage to the glomeruli and the nephrons, and we have inflammation. And so it's really hard to filter our fluid and our urine into down and out of our bodies when we have this damage and decreased filtration. This usually is shown by a decrease in glomerular filtration rate, and we can have decreased urine output, or we can have oliguric or anuric, which is no urine output at all. This in itself then causes hypertension or hypovolemia because we are not filtering our urine out and it's staying and circulating in our body, which then also increases our risks of toxins and electrolyte imbalances. With the antigen and antibodies and the extra fluid, we actually get hyperpermeability of the capillaries. And when the hyperpermeability happens, we actually will then lose RBCs, albumin, protein from the vascular space into the interstitial space. Now, you might think that that would cause a big fluid shift because we're taking our albumin, which is hypertonic, and moving it into our interstitial spaces. But in fact, with this particular disease, and this is our disorder, this is the difference between acute glomerulonephritis and our next one that we're going to talk about, which is nephrotic syndrome. the albumin and protein loss for acute glomerulonephritis is actually mild. So we really don't lose, much, which means that we don't go hypotensive, we stay hypertensive because we're not ridding our body of the fluids. Also with hypertension, if our kidney is not being perfused properly, it could actually instigate the RAS system, because the RAS system wants to rid of or perfuse our kidneys properly, and that then makes this hypervolemia even worse. Okay, so going to the nephrotic syndrome, it's typically idiopathic in nature. However, two main secondary causes are diabetes and lupus. And this is an exacerbated disease process from that acute glomerulonephritis, which means that the glomeruli are far more damaged, which causes an exacerbation of that capillary permeability. So this is what we were kind of talking in the previous slide, except it's exacerbated. So because this is an excess of fluid shift, the albumin and protein in the water actually leave the vascular space in massive amounts into the interstitial spaces. This will show that in the patient, as you will notice, an increase in edema from the fluid shift and a decrease in the blood pressure. So this is when this hyperalbumin comes into the interstitial spaces, and then the fluid leaves the vascular space and goes into the interstitial, causing edema. Okay. So in the next slide, we'll go over the meds, but really what we need to fix this, right? Well, first we have to try and fix the nephrotic syndrome. We always want to fix the cause, but until we do that, we need to fix the side effects. Because this patient could become so hypovolemic that they might need something called a vasopressor, which is an ICU medication which increases blood pressure without the extra fluids. But if we give them IV albumin, so we can give them albumin in the IV, and we can get the vascular space hypertonic, then it'll pull the water molecules that are in the interstitial spaces and then pull it back into the vascular space, which will increase the blood pressure. Okay. So that is kind of a quick fix for this as far as blood pressure is concerned. But our primary fix is to fix the damage in the glomeruli or the kidney. So remember, because we have all of this albumin here, the urine that we are urinating out has massive proteinuria. Okay, so we have tons of albumin leaving our body, both through what is left of the kidney and then also into the interstitial spaces. So we've talked about some of the treatment that we do already. So our glomerulonephritis, we're going to try and treat the cause with antibiotics if it is strep. Our diuretics, I want you to remember when I say diuretics and we're talking about the kidneys, that is, we can only use that if they're actually diuresing, if they're actually urinating. If they're not urinating, we cannot use diuretics because that will actually build up more fluid in their system and cause their electrolytes and everything to be even more unstable. We can give antihypertensives though to decrease blood pressure because it works in a different manner. It doesn't work with the kidneys for the most part. We can give steroids for that immune response, and we can give corticosteroids or we can give DMARDs depending on what is most appropriate for the patient. And so then kind of on the opposite spectrum, we've got nephrotic syndrome, right? So here we want to decrease blood pressure, but here we want to increase blood pressure. I'm going to get back to this diuretic in a minute, but we want to get IV albumin, like I said, to get that the fluid and protein back into the vascular space. And if we do that, and they are diuresing, we can then give diuretics that help flush the kidneys. Okay, but the primary use for the albumin is to increase that blood volume and the vascular space because right now they're hypotensive. Again, we can give steroids depending on the cause. ACE inhibitors work well because they decrease protein loss in the urine, but again, ACE inhibitors are because it's the angiotensin converting enzyme inhibitor, but this will also depend on the patient's blood pressure. Okay. And then heparin has been known to work well in most kidneys disorders. But what it does is it improves the kidney function and it helps prevent some small clots, especially if they're dehydrated or have hypovolemia. Clots are more likely to form, and so it's going to help prevent those clots from forming.